Um, good good afternoon, good morning, good evening, everyone. Thank you for joining us today. My name is Frey Hewitt. I'm the Executive Director for the International Institute for Primary Healthcare, Ethiopia. Uh, Today we'll be having our session on multisectoral collaboration and primary healthcare. I think this has been a long-awaited session for those of you who have registered uh, a while back from our page. And it's also a very important pillar of primary healthcare. So we're really excited to have our speakers and moderators today on board to discuss this important uh, component of primary healthcare. So I don't want to take up much of your time for discussion. I'll introduce our moderator for today, and then I'll hand it over to her to take it from there. So we have Dr. Savaya Closer with us today. She is an assistant professor at the at the Johns Hopkins Bloomberg School of Public Health at the International Department of Health. She recently joined our team from Hopkins side. She is the principal investigator of some of our grants. We really enjoy working with her so far, and we look forward to the future engagements as well. Dr. Savaya has a lot of experience around social and behavioral engagement, and she also has experience around primary healthcare. Let me hand it over to Dr. Savaya to take it from here. Thank you, everyone. Over.
Thanks so much, Dr. Freywood. It's always wonderful to work with everyone at IPHCE. And I'm so excited for our panel today. I'm going to get right into it by introducing our first panelist. Dr. Shalini Singh is my colleague at Hopkins. She works on several health system strengthening initiatives that we have within India. And she's actually India-based. Prior to joining Hopkins, she was working with the National Health Mission, with the National Health Systems Resource Center, where she was involved in the design of the ASHA program, which is a large community health worker program within India. And she's currently working on several research projects around multisectoral collaboration. So I don't want to take up too much more of her time because I want to hear from her. She's also a lovely person and a wonderful colleague. So I'm really looking forward to hearing from her today. And Dr. Shalini has a lot of experience and insight of what's happening within India as well. But we've asked her to give today an overview of multisectoral collaboration from a global perspective. And perhaps in the discussion, we can get into a bit more talking about the India experience, which we'll also hear from Dr. Amarjit Sinha. So Shalini, over to you.
Thanks, Soya. Thanks for the lovely introduction. I'll straight away jump to my presentation because the time seems to be really limited, and I want the audiences to get the most of it. But it's a wonderful opportunity to talk in front of such immense group of audiences about multisectoral collaboration and primary healthcare, a topic which is very, very dear to me. So the task which I have been assigned by the team is to give you a global perspective about multisectoral collaboration and touch upon the theoretical underpinnings which underlie the multisectoral collaboration. I have a small tech issue here. I can't change my own slides. So if somebody can jump in and help me with it, it would be great. So next slide, please.
You should be able to change it. Should I share your slide from my side? And
I'm not able to do it still.
Yeah, so maybe you can try Alt with tab and go to the full screen tab. Otherwise, I can share the slide from my side.
Would you do that, please?
Okay. Thank you.
I'm so
Thank
sorry
you.
about it. But yes, so the presentation today, which I'll be making, would primarily be covering some of these important aspects of multisectoral collaboration. I'll touch upon uh, just the concept of multisectoral collaborations, the key definitions, what have been the global policies around multisectoral collaboration with respect to PHC, some concepts and frameworks which are pertinent in the low and middle income country context, key enablers and challenges. And I'll just give a very quick example of how health sector can see several opportunities of collaboration around the risk factors to improve the health outcomes, which is primarily from the health in all policies of the WHO. Next, please. You can move to the next. Yes. So all of us would agree, and there is a generalized consensus now. I think every country, every public health expert and across sectors would be convinced that merely access to health services or a development of health sector alone cannot solve the root causes of poor health, and which is primarily living conditions, environment, income, education, our social support and relationships. All these causes are pretty complex. They are interdependent with inequalities which are low income country contexts particularly face, and they require collaboration of different sectors, community groups, and most importantly, people themselves. So what is multisectoral collaboration all about? Fundamental to this is action on inequity and action on health inequalities. There are several synonymous terms which we use for it. Somebody calls it intersectoral collaboration, somebody calls it cross-sectoral. But the idea here is that it is an overarching term which is used for highlighting collaborative working approaches to improve health and well-being. It may be called whole of government approach, it may be called whole of society, health in all policy, healthy public policy, or joined up government. Next, please. So I have two definitions here from the literature. The public policy literature is full of definitions about multisectoral collaborations. I was kind of biased. I picked and chose the ones which I liked. The first one is a little more common in the public health world, which is Public Health Agency of Canada, and WHO coined them in around 2008. And this is calling multisectoral collaboration as an intersectoral action for health and well-being, which brings different sectors outside the health together. It may involve health sector or it may not be with health sector. But the idea here is to either address the health or health equity outcomes or the determinants of health and health equity. The second definition, which I related personally with, is not just pertinent with health sector, but this is collaboration across two or more sectors. It involves government, civil society, private sector, but most importantly, it involves people and community themselves who come up and together solve a social problem which is very complex and cannot be solved by one sector alone. Next, please. So this is just a quick overview of what have been the global developments around multisectoral collaboration and PHC. So the literature is saying that, the development around such collaborative governance regime or multisectoral regime started in the last, the impetus has been there in the last 40 years. There's some historical evolution which dates back to 1974 in Canada from Lalonde report, where it was said that the whole of government approach is necessarily needed to address health promotion. We are all aware of Alma Ata, which emphasized primary healthcare approach for health for all, but it also at the same time emphasized on related sectors' involvement to promote health and well-being. The Ottawa Charter is very much there for health promotion and health equity. Next, please. We know about the WHO Commission on the Social Determinants of Health, which address the root causes, which I alluded in my first slide. I particularly like the statement from the Rio Declaration, which speaks about health equity. And it emphasizes that if health equity needs to be addressed, it's a shared responsibility. It requires engagement of all sectors of the government, all segments of the society, and also all members of the international community. So all of us sitting together here, we are all jointly responsible to address health inequities. The World Health Assembly 67th session further reiterated. Next slide, please. And now in this modern world, in today's era, agenda of 2030, we have the Sustainable Development Goals. All of us are familiar with this. We know that each of these 17 goals are pretty much interconnected. If one goal needs to be achieved, it cannot be achieved without action on the other goal. So if one goal has to move forward, it involves tackling specific issues which are determining the progress of the other goal associated with it. Next slide, please. The 2018 declaration of Astana on primary healthcare is particularly important. I really liked one thing about this. Of course, health for all and health and well-being is central. But what this declaration says is, if we need to achieve health and well-being, it cannot be without synergistic actions on three fronts. One is the multisectoral policy and action. The second one is empowered people and communities. So it's coming more strongly this time, and then linking it with primary healthcare as an essential public health function, which relates and interconnects with both multisectoral approaches and empowered communities. Next slide, please. So trying to demystify a little bit what entails in this multisectoral collaboration. How does it get unfolded when one tries to attempt it? So we need to see it as an evolutionary pathway, which goes from cooperation to integration. The end goal is not an achievement in itself. Each of these stages are not mutually exclusive, but they sort of overlap with each other. It starts with some sort of a cooperation where the different sectors come together, still maintaining their siloed approaches, but start sharing some information and resources. Moves to coordination, which is a little more nuanced. They start working collaboratively and start doing some sort of a loose planning to move towards a shared goal. We come towards collaboration, and which is a little mature stage where we enhance one another's capacity, start sharing actually our resources and personnel, facilitate some strategic planning, and then graduate to a more highest order of relationship where the boundaries of different sector, they get faded away, and we just have the end goal in front of us. Next slide, please. So there's a framework which is particularly important in the context of low and middle income countries, which helps in understanding the processes and key components of multisectoral collaboration. It starts with the prerequisites. What are the prerequisites? Then we have key drivers. We need some mechanisms and processes. We need some structures, administrations, and execution. I won't go into all the details of the key components here, but just taking one of each of this. So what are the key requisites, key prerequisites of multisectoral collaboration? Of course, one is a buy-in in the process. Unless you have it, unless everyone is convinced that multisectoral collaboration is the one strategy which will help us in improving outcomes, we just cannot proceed further with this. We need resources. We need to recognize interdependencies, and that's where the role of technical partners come into existence, that they give us the rationale of why do we need multisectoral collaboration. The other key drivers are leadership. Someone needs to drive it. And we have seen from some of the studies which Swaya and I have been doing within India's context that wherever political leadership and political commitment has occurred, the outcomes have been tremendous with respect to multisectoral action on health. You need mechanisms and processes. You need multisectoral task forces. You need multisectoral committees. But there needs to be a structure. You need to give them a mandate, specify memberships, roles and responsibilities, and some sort of standard operating procedures. Also critical is administration. We somehow tend to, these concepts tend to become very fluffy when it comes to implementation, but yes, they're very critical. Who is setting up the meeting? Who's documenting the progress? Who's following up on the action plans which were decided in the meetings? And then the execution, without which all of this will fail. So some decentralized process of orders and guidelines, coordination and management, and resources for implementation. That's the key. But to the end, we also need a double loop learning system, if I can call it. It has to be an iterative process, understand what we have done, what has been the impact of collaborative initiatives, what has been the outcome, and where can we improve. And one of the gaps which is emerging from the previous literature and from our own study is we need to build exemplars and best practices where we show the impact of collaborative action. That's where low and middle income countries and low income settings are really falling short. So come up with exemplars and best practices, showcase them, and use them as a advocacy toolkit. Next, please. I think this is very much there in the framework. I will not go into the details of enablers and challenges, but moving to my next slide, please. So this is a very busy slide here, but it's directly from the Health in All policy document of WHO. I'll just take one example of how opportunities of convergence can be leveraged. Let's take the example of air pollution, which is number 3 here. Air pollution leads to, it's a risk factor leading to poor health outcomes for cardiovascular diseases, chronic obstructive pulmonary disease, respiratory infection, and lung cancer. Now, how can health sector, what are the sectors with which we can converge as health professionals, as public health people? We can converge with city governments, municipal corporations, municipal bodies, the energy sector, the transport sector, the industry, the urban development. All these need to come together if we need to see some impact on air pollution. And it's only when we collectively work together that the SDG targets, the 6 targets that are outlined here, would be impacted. So that's the importance of collaborative action. And this is just one slide. There are many more examples of how do we achieve a sustainable and integrated development. This was just one example. I just want to end my talk with one small key takeaway message. I think it's high time. We are in an era of public health 3.0. We all need to actively build capacities, come up with health strategists who champion multisectoral collaboration, not just at the national or state level, but in every county, in every district, in every village. There have to be health strategists who know the nuances of how it is done. So collectively, I think what we need to move now is towards a very practical toolkit, which can demystify all these aspects of intersectoral collaboration. Thank you so much.
Thank you so much, Shalini. That's a wonderful presentation. And as we go through these presentations, feel free to put your questions in the chat, and we'll try to get to as many as we can at the end of all the presentations. I'm very honored next to introduce Mr. Amarjit Sinha. Has such an illustrious career that it's very difficult for me to summarize it in 1 minute, but I'll hit a few of the highlights. For our purposes, one of the major things to know is that Mr. Amarjit was involved in the creation of India's National Rural Health Mission, which is a huge network of primary healthcare across the entire country of India. He's also worked with the Public Health Foundation of India and has a forthcoming book, The Last Mile, Turning Public Policy Upside Down. So I think that probably resonates a bit with some of what Shalini was saying, although I will let him tell us more about his thoughts on multisectoral collaboration. Welcome.
Thank you, Swaya, and I think Shalini has put the context very well. Friends, first and foremost, we all know that every minister in a council of ministers is a health minister. If I don't breathe well, if my industry leads to a lot of occupational health, if I grow crops which spoil my health, n number of examples from across the sectors, from drinking water to sanitation to a whole lot of requirements. And clearly every minister is a health minister. So where do we draw the line, if at all, in the structure of governance? Because clearly, as Shalini pointed out, multisectoral approaches also require institutions. They also require systems which are able to hold this together. Now, again, I'm familiar with some of the work in Ethiopia. In fact, when the health mission began, Dr. Sundar Raman and others, the team had gone to Ethiopia as well. Dr. Taimuru and others may be aware of it. And essentially, what we were trying to do is to learn from each other. What are the challenges and how do we overcome those challenges? In our case, in the case of India, and again, I think what I'll try and do is there are some very universal principles which holds true everywhere, but there are also some country-specific issues. I will try and make a mixed match because clearly the local and the global health is one sector where the local and the global both have a very major role. The global because that's where science and technology and research comes from, and the local because without the community connect, without the holistic frame at the level of communities, there are limitations to where we will reach. The second principle, which is important to understand, is that nobody is coming from the private sector to do public health for you. You have to realize that a lot of those challenges and what Kenneth Harrow said many, many years ago with regard to information asymmetry and health actually holds good even today. In spite of all the efforts that have happened in secondary and tertiary care, but a lot of the responsibility for public health is with states. Therefore, there is no going away from what I call crafting a credible public system. You need a public system, and that's what most countries which have managed to tackle their challenges well, that's what they demonstrate. And in our own country, some of the provinces which have done very well, Tamil Nadu, Kerala for one, clearly bring out the positives of a system where the countervailing presence of a functional public system of healthcare has consequences for the quality and cost of care offered by the private sector. I think it's an important message that investments are needed. It's not that we can do without it, but the important lesson also is that it can't be in compartments. People's lives are not compartmentalized. What house I live in, what water I drink, what food I eat, all of them determine how healthy I will be or how disease-free I will be and what my level of well-being is going to be. That being the case, by very definition, multisectoral approaches require breaking down of walls. And I'm afraid many a time, we ourselves, and especially the funding agencies, both national and global, whether it is central government, state government, provincial governments, local governments, or whether it is the multiplicity of agencies working in this sector, multilateral and bilateral, each one of them, they want their own systems. They want their own MISs, but they still want convergence. I think a lot of these challenges have to be addressed. In fact, one of the reasons why we set up the National Health System Resource Center, and we insisted that we will do it only with domestic money, for the simple reason we did not want our systems to be compartmentalized. The health MIS that we had worked on, the intent was to be able to get a holistic picture of not only reproductive and child health, but what is happening on communicable, non-communicable, promotional, all of the preventive. So I think the important lessons are, as far as systems are concerned, they have to be holistic. Communities have to be connected at the local level. Now, public expenditures and crafting of credible public systems has to be a thrust. But on this debate about, because among the economists all over the world, the famous debates about the trickle-down theory have high rates of growth and everybody's well-being will get taken care of, to the alternate view of Amartya Sen and others that no, it's about human capabilities and therefore you need to invest in human development. The third area which we discovered and which we worked on over the last many years is the area of what I refer to as the asset deficits that poor households suffer from. Whether it is the denial of electricity, whether it is the denial of clean water, whether it is the denial of sanitation, toilets, housing, and so on. A lot of the effort which I have had been party to in the last 7-8 years in my own country has been in this sphere, or what I refer to as the asset deficits of the poor, also referred to by our Honorable Prime Minister as an effort to improve the ease of living of the poor. Have we been able to provide functional toilets to every household? Are we able to provide piped water, clean water supply to every household? Are we able to provide electricity to every household? Are we able to provide gas connections so that women don't have to suffer the smoke and spend a lot of their time just collecting firewood to be able to keep the cooking hearth going? I think a lot of these are important because clearly, in the ability of an individual or a household to access public services, what we find as you improve the asset base of the poor, remove the asset deficits of the poor with regard to electricity, housing, gas connection, toilets, and so on, drinking water, roads, public transport, automatically it translates into better utilization of many of those services. An important lesson of multi-sectoral approaches, institutionally, for example, in our country, in India, we had, and again, Ethiopia is no different, we have all democratic nations have a structure of democratic decentralization, which is to do with institutions of local government, provincial government, and national governments. Now, the problem is that our constitutions in our respective countries say this very categorically. But the problem is each time, even at the local level, when you have elected public representatives, the challenge there is that oftentimes when I create a monopolistic authority of local governments, it often, like any other monopolistic authority, tends to become arbitrary in its exercise of authority. Now, how do you take care of it? Now, this is where institutionally the countervailing presence of what we in India call the women's collectives or the self-help groups, something which happened in the southern Indian states initially, Tamil Nadu, Kerala, Karnataka, Andhra Pradesh, Telangana, and which has now over the last 7-8 years happened all over the country. Today we have more than 90 million women in rural India who are a part of the livelihood mission and women's collectives. And a lot of our effort has been to get them to work with the elected representatives of panchayats. We celebrate the local government and its democratic decentralization in the state of Kerala. Oftentimes, we don't adequately recognize the accountability to local communities, which was built into the approaches in Kerala. It wasn't just the elected representative exercising monopolistic authority. The neighborhood household groups was integral to it. So the lesson for multi-sectoral partnerships, you need institutions, you also need community organizations, countervailing community institutions, which are able to hold it accountable for what it is to do. Now, in democratic nations, for many, many factors and reasons, for example, in our country, in India, the decision to decentralize, amend the constitution, while it happened many years ago, 1976, the 42nd Amendment to the Constitution. But the challenges are that oftentimes those institutional changes are about deepening democracies. For example, on account of positive discrimination which our country has followed because of some of the social hierarchies, the scheduled caste and scheduled tribes, or women. In the case of local governments in India, 1/3 of the seats are reserved for women. Many states, many provincial governments have made it 50%. As a consequence of the 3.1 million elected representatives in rural local governments in India, 43% are women. Here we have the 90 million women in the women's collectives or the self-help groups of the Rural Livelihood Mission. And here we have the 3.1 million elected leaders of local governments. If we are able to get them to work together meaningfully, along with all the frontline worker forces that we've created, in our country, the ASHA worker that you mentioned, the Anganwadi worker who looks after the integrated child development services, the auxiliary nurse and midwife, all of them, the community cadres. So if the local frontline workers, as also the ASHA health workers at the cutting edge level, local community organizations like the women's collectives is one example. There may well be other examples. In tribal areas, we have large habitation specific community organizations which play a similar role. It could be in any form, but basically which interfaces with formal institutional resources. And I think once this countervailing presence becomes sharp and very active, then multisectoral approaches and convergence have a real chance of success if we accompany it with funds, functions, and functionaries. Now, in our country, what has happened is that initially we brought the amendment and we pushed the funds, but we didn't create these capacities. We didn't create countervailing community institutions in many provinces that were required. As a consequence, my own province of Bihar, which has perhaps very unsatisfactory indicators in health, the challenge there was that when you pushed in too much money to local governments, a lot of wastage, a lot of corruption, everything comes in. But when you have in that same state of Bihar where I belong to, today we have the women's collectives in every village, the Jivika program, which holds elected representatives accountable for delivering what is expected of them. You go to a village and they complain that the food rations are not reaching regularly. If you ask the villagers, they'll only say one thing: give it to the Jivika Didis, give it to these sisters of Jivika, everything will be fine. Now, this connect of community organizations with the institutionally elected leaders, then once that frame is in place, now in the case of India again, the constitution in the 11th and the 12th schedule has identified these 29 sectors which have to be the mandate of rural panchayats, and in the 12th schedule 18 sectors which have to be the mandate of urban local bodies. For making it operational, you need to get that planning process going from below. You need assessments on how those panchayats or local governments are doing. Therefore, it becomes important to measure infrastructure, public services, human development, and all at the village level. I'm happy to report that this is the exercise over the last 8-10 years we've been doing. The Mission Antyodaya, which means the last person in the line. Today, we have data for 2017, 19, and 20 for every village on where it stands on 143 different parameters formally vetted by local communities. It threw up a lot of challenges because a lot of claims of departments and governments were actually, when it came to their validation by communities, they didn't agree. For example, in many places, the open defecation free village, the communities did not certify it, local officers had. So they had to redo the entire exercise. So in many ways, triangulation with the community at the center of it gives you a benchmark of where you stand. Multi-sect, because whether it's education, nutrition, health, livelihood, and skills, at least for these. And therefore, in fact, I've recently just done a piece day before yesterday, which is on India's leadership of G20. And my argument is that the UN and the SDG system, unfortunately, they remain platitudes many a time because they're not backed by adequate resources. So if the G20 is an economic formation where 80% of the GDP and 70% of the growth is happening, let these countries commit themselves to a human development mission with the local in front and global in its perspective, which actually tackles some of these challenges. Financing of hard infrastructure should come second. Human development is where, whether it is Ethiopia, whether it is Nigeria, whether it is India, whether it is any of these developing countries, we need to put our money for human development. We need to put it in a frame of community accountability with institutional decentralization. We need monitoring systems that are real time. Technology allows us that opportunity. I realize that I've just overshot my time and I stopped here. Thank you. Sorry.
No, thank you so much for that inspiring presentation. I appreciate it so enormously, and I'm sure that it'd be much for us to discuss, and it's given me a lot to think about and to consider. So next, we have another distinguished panelist, Dr. Tamiru Wande, has also a long and illustrious career with much experience. And again, I'll just hit on some of the highlights. For the purposes of this panel, what's perhaps most relevant is his work with the Ministry of Health in Ethiopia, on multisectoral WARDA transformation. So building on perhaps what Dr. Amarjeet just discussed, Dr. Tamiru will be able to talk to us about what's happening in Ethiopia at the WARDA level, so the local district level, in terms of thinking about multisectoral collaboration, some of the lessons there, and some of what we can take from that. Thanks so much for being with us and look forward to hearing.
Thank you, Sylvia, for your introduction. Let me share my slides. Let me check if you see my slides. Do you see my slides?
Nope, unfortunately, I just see the webinar. I see me.
It was shared, but you need to click on the PowerPoint. Please reshare again.
Do you see now?
Not yet. Yeah, it's coming now.
What about now?
It came. Thank
Yes,
you.
we have it now.
Thank you all. Good morning, good afternoon. Thank you, Sylvian, for your introduction. So I will be taking you to the Ethiopian experience where we have been engaged on multisectoral to realize the SDGs and improve the primary health care. So this is the outline of my presentation. I will be touching what multisectoral engagement look like in the context of Ethiopia. Why would that multisectoral engagement and collaboration was done, and how was it implemented through the process, and a bit of the experience we had and the challenges, and what are the next recommendation will be presented. So as it was said, the definition or the meaning of multisectoral is a deliberate collaboration of various stakeholders to realize and achieve a common desired health outcome, as health is being determined by a number of factors outside the health sector, and including other social determinants, environmental and economic factors. So multisectoral engagement addresses holistically and improve the health outcome at large. Why was it implemented as a multisectoral in the context of Ethiopia? So engaging multiple sectors and partners can leverage knowledge, expertise, skills, and resources, and maximize health outcome. So sharing the quotation by Aristotle, the whole is greater than the sum of its parts, will directly amplify the concept of multisectoral. So working together maximizes efficiency and results. So we might run alone and we might be fast, but going together will sustain the results, and we will run longer. So the concept of multisectoral engagement encompasses synergy in terms of integration and collaboration. It maximizes resource as it integrates efficiency, and it avoids duplication of work as we move the design together, and aspires to see the bigger results and sustain the results longer. So it's a kind of identifying intersection, working together in a collaborative manner. That has been implemented through a number of things. So bringing all stakeholders that are interested around the agenda together on a table, identifying and come up with a common goal and vision to work together, and then flashing and dissecting the critical elements of sectoral and multisectoral elements so that we can amplify on the intersection and results could be maximized. So there should be a kind of body that helps us to lead and coordinate these multiple actors, partners, or stakeholders. Roles has to be defined because there is a kind of common agenda. At the same time, there are specificity and cross-sectional activities. So defining roles and responsibilities is very critical. So bringing package of intervention together so that we can push that activity is very critical element in multisectoral engagement. There has to be also a kind of vertical, diagonal, and horizontal communication and alignment and integration towards moving this common agenda. As well as it was said, mobilizing resources, committing, dedicating is very critical in terms of realizing the common vision. And there need to be finally an agreed upon one plan, one budget, and one MNE toward the common agenda that is being drive toward this multi-sectoral. So there is also be a kind of binding or non-binding agreements among the stakeholders or the sectors to move things forward, and conducting regular follow-up and tracking of the deliverables and ensuring accountability was the means to realize this multi-sectoral achievement. To show you the Ethiopian experience in terms of multi-sectoral engagement, these are examples how the government of Ethiopia is pushing some of critical elements of nutritional program as well as one wash program and multi-sectoral Warada or district transformation. As you know, the National Nutrition Program with Sakota Declaration is a big program nationally to decrease and end the stunting, where multiple actors within the government sectors as well as from non-government and civil society were engaged to work toward this ending this stunting and hunger. That has been done for multiple years and more than 8-9 sectors and multiple partners working towards that with an experience that Ethiopia had. And the other bigger program, the One Wash National Program, where 4 sectors, including health, education, water, and finance, with all the donors and civil society work towards improving access to water, sanitation, and ensuring the availability of these wash services in school, in urban and rural setting. That's also one of the experience that Ethiopia was doing through a multiple joint coordination team at the higher level and the technical team, and following and monitor with clear deliverables and program tracking. And the recent experience that we had to realize the SDG and realize holistic approach at the community is a multi-sectoral or the Warada or the district transformation to see the society transformed in terms of livelihood, economy, health, and other sectors. So the health was the one that initiated the Warada transformation within the health sector. That has expanded and galvanized other sectors to work together and come up with a kind of model to help realizing the SDG at the local level. 8-9 sectors with partners have been engaged to realize this multi-sectoral collaboration at the district level. Just it was tested through a kind of proof of concept or a kind of demonstration at a single Warada to see how the SDGs would be realized by bringing all actors at the district level, where everything would be initiated at the household, at the community level, so that the bigger aspiration would be realized. Gimbichu was one of the districts selected to realize that multi-sectoral Warada transformation. And Gimbichu, as you know, it is a place where the recent deadly air crash, Boeing 737 MAX, has happened. And it is 65 kilometers from Addis in the northeast of Oromia, and with a total population of 120,000. It has 3 rural towns and 33 sub-district villages or kabales. So it was started with the concept of how household transformation would be realized to see the bigger aspiration of SDG. And interested sector come up around the household, the 8-9 sectors: Ministry of Agriculture, Ministry of Education, Health, Water and Irrigation, Ministry of Transport, come up with identifying their intervention, their activities that would anchor on the household level, and then start the change from the household to the community, and then the district and the national bigger aspiration would be realized. This is how it was started as a model, and the framework was to see changes at the household in terms of critical interventions and indicators, and then see village or sub-district structure would be transformed, and then the district level, the zonal and the higher level, regional and national level changes and aspiration would be realized. So it assumes a kind of reverse transformation changes that is not anchored, that the household would not realize the bigger change at the national level. This was the model of convergence. All the sectors come up with this kind of model to start the activity with a single order and at the household level. The concept of multisectoral in the concept of order transformation is it is a kind of aspiration of the Ethiopian government to see a transformed district or woreda. And it was assumed to be a path toward this development by anchoring on the household building blocks, and it assumes reverse direction of transformation. So the bigger outcomes at the CDG would be realized if we start changes at the lower level. And it's a means at the health sector, a means to primary health care and universal health coverage, and at large, it realizes the aspiration of the aspiration to SDG. And it breaks down the macro level aspiration into a micro level intervention at the ground, and it was linked with all the 17 goals of SDG, with 11 direct and 6 indirect SDG links were entertained. This is how it was initiated. So the framework, all sector identified programs, interventions, and solutions that they were implementing at the community, at the facility, and at the district level. And they were mapped with sector-specific and multi-sectoral woreda transformations. They defined, they identified intervention which are very sector-specific and which are multi-sectoral, and they categorize with a level of input, process, and output, and they come up with a package of intervention at the community level where householders or communities would be benefit out of it. So that all sectors come up with breaking these interventions within their sector as well as within the multi-sectoral to anchor the activities at the household. And the other package of intervention is the facility level service delivery package, where every sector uses service delivery points at the community. Could be schools, could be water schemes, or agricultural, or health center, and so on. So every sector break down all the activities and indicator that anchor on the health facilities or the service delivery points. And then leadership, that governance, that coordinate this activity at the lower level. They identified some capabilities and gaps, interventions that would help lead this intervention at the lower level. And then this all add up to bring a change at the larger scale within the community, called a model woreda or district, that package everything within the sector as well as cross-sectoral. And that has been mapped with the SDGs indicator that addresses social services, economic opportunities, that addresses equity gaps, environmental targets, and peace and security. So 20 indicators within this kind of approach could be answered to ensure the high-level outcomes at the national level. Within them, the sector-specific as well the multi-sectoral outcomes have been identified, and the overall aspiration of change would be demonstrated at the district level by model householders, model institution, as well as model leadership capability at the district level. With this reverse direction, we can ensure the higher level of aspiration of SDG, like ending poverty, ending hunger, and increment in GDP per capita. And through that model, a single pilot test or demonstration have been started on Gimbichu, and there has been a kind of multiple deliberation to come up with that kind of demonstrating in one woreda and scaling up at multiple larger point is a critical decision made by the top leadership to see how that would be anchored and translated into reality. And there has been multiple missions through the ministers as well as the technical experts to come up with the packaging the intervention at the lower level to guide the strategies and so on. The steering committee, led by the ministers, were frequently meeting to see how that goes. And as part of the technical team, I was there, and the technical team from all the minister were identifying intervention as sector specific and multi-sectoral and packaging them within the community, the facility, and the district level as well, defining the indicators and so on has been done. And then a kind of baseline assessment of all the facilities, the community and the household level assessment were made, including the capacity at the lower level, and intervention packaged and plan was endorsed and started the implementation. Through that process, multiple actors from all the government partners as well as donors and implementing partners pool their resources and work towards improving social services, schools, education, and agriculture. This is the picture that you see is the health and the education sector working together to improve wash services as well as improving behavioral change communication at the school, as an example. This was the stage, the demonstration stage where it is under implementation. We'll see how it would be at the end of the process. The other experience we had is while we are implementing HSTP1 between 2015 to 2020, there is one of the agenda called Warada transformation that the health sector is leading. So that concept of Warada transformation is the one that involved into a multi-sectoral that is being piloted. So the experience on the health sector to define what is a model district, what is a model village, what is a model house, and what is a model Warada, and so on have been implemented in the last 4 or 5 years. And there are metrics, indicator that defines what is a model household. At the household level, there are packages of intervention through the health extension program. While families implement that, they would be model. So depending on the level of grading, they would be given a kind of model. And there is also a kind of health center or primary health care level of analysis or metric that defines the level of their performance that addresses the 12 chapters in terms of their quality and so on. So these facilities would be graded as high performing, low performing, or medium performing. The other category that the health system was using was the availability of resource and finance through the CBHI, that is the insurance. So the community-based health insurance, it would be graded based on their contribution and so on. The Waradas with mobilizing their resources would be graded to have a kind of indicator and metrics as a composite. And the other is the Warada leadership capacity, how they mobilize the resource, how they coordinate things around, and so on. So this was the experience, and it has been a good experience. Before 3-4 years, there was no Warada that has been shown to be transformed. Later, it started with 8 Warada. Now it evolves to reach into 60-70 Waradas to be transformed across the nation. So there was a kind of sharing of experience among the Waradas through this dashboard tracking. Waradas will fill it through self-assessment, and the federal or the regional body will independently go to the facilities and the Waradas to assess and verify the score and so on. That brings a kind of momentum and changes around. So model Waradas, model facilities, and model districts have increased. And this learning, the new learning, multi-sectoral engagement with all the sectors at Gimbichu would be the one that would add further to the missing element. This is the dashboard that has been tracked by the ministry. The number of Warada reporting has increased. Totally, there are more than 1,200 Waradas nationally. Of them, 72% now they report with self-assessment. Out of more than 4,000 primary health care units, 75% now they are reporting with self-assessment in terms of their community, facility, and leadership standards. And number of Kabbales out of the nation, more than 18,000 Kabbales, 77 have graded themselves and come up with their evaluation. So recently, we can see from the lower graph that there is an increment in the model performing facility. So it is gradually increasing now. As per the report in June 2022, just this year, the proportion of model Kabbale reached out of the report 10%, high performing 19%, and model Kabbale is 23%. This is promising, and it needs further follow-up to see all changes happen. And the challenges were, by design, understanding the concept of multi-sectoral is very critical, and it was difficult even to understand and see how that aspiration would be translated in the household, and translating that into implementation was very challenging. So understanding the concept was one of the challenge, and technical and leadership capacity to lead these things at the lower level was a challenge. And through multi-sectoral collaboration. Results are not very quick, but they are sustained. So that might have a kind of negative energy because results are very far and it is slowly incremental. And the other is there is a kind of a momentum of multi-sectoral engagement that was high at the beginning and later it was decreasing from the leadership and so on. So keeping that momentum need to be one of the areas that should focus. So momentum has to be sustained. If there is a change, the performance has also been affected. The priorities of the committee has been variable. There are things that come and go with the community, with changing the weather condition, the change in the COVID and the change in the harvesting season and so on. That was also affected the performance. Resource is obvious. There has been a kind of costing exercise. How much does it take to transform a woreda was exercise in terms of all aspects, and that is huge, but that needs a kind of catalytic resource to further see how changes would be maximized. And the coordination and the ownership, specifically in multi-sectoral, unless it's owned and ensured by the sustained manner, that is a challenge. Specifically to the health sector, there are few challenges that are identified. So within the health sector, even leading this transformation among the directorate departments needs to be maximized. If there is a kind of miscommunication, not understanding things well, that would drag the results back. And the lack of integration and performance tracking, this tracking from the ground came through a kind of a different means, and is not integrated with the DHIS too. So integrating it would maximize the accountability and the visibility. And some of the woredas have a kind of regression in performance. They were once model, and in some of the time the CBHI might drop and the PHC performance might drop and so on. So sustaining it, keeping it a higher level needs a kind of a different approach. So keeping them is also costly. Self-assessment verification reports were having discrepancy in terms of quality. So woredas assess themselves as high performing, but when independent assessor goes, there might be some changes. So there might be a need to go into data quality issues and so on. These are some of the infrastructure issue, the finance and the leadership turnover is also a major challenge that we have seen. And the recommendation that to see a multi-sectoral being realized at the local, they ensure UHC, primary health care and SDG, the leadership engagement should be sustained and there should be a regular follow-up to see its success. And there need to be a kind of dedicated resource in terms of time and money, as well as this lesson that should be documented to future learning and evidence generation. Thank you very much. This is all. Over.
Thank you so much to all of our panel. No, thank you so much for all of our panelists. You've given us so much to consider. So please put your questions in the Q&A box. I'm going to start with a couple of questions and comments that are related and very difficult. So Shalini, I'm going to start with you for this extremely difficult question, which is really about how you get people on board. I mean, I don't expect you have an answer to this, but I'm interested in your reflections. There's a question. Betsamariam posted a question, who from the government should be taking the driving seat to bring all responsible sectors committed and accountable for? And I saw some other discussion in the chat about, yes, we all know that multi-sectoral collaboration is important, but how do you actually get other sectors involved? How do you get them to care? How do you get them to follow through? So I'm wondering if you have any reflections on that very complicated question.
Yeah, I mean, of course, from Indian context, Mr. Sinha would be able to elaborate it much better, but I can just start with the experiences which I have been having, particularly interviewing the people who are at the district or the county level in India and the sub-district level. The key challenges in stakeholder engagement primarily is the incapacity of some of our public health experts themselves to undertake this intuitive communication with the other stakeholders, making them understand why do the two sectors need to collaborate and helping them understand that outcomes of one sector are also influencing outcomes of another. Most of the time stakeholder says, but we are doing our work very well. That's the understanding which different departments, particularly within India, for nutrition, let's say, women and child development and health need to come together quite often. So not that one sector is not working hard or stakeholders from one sector are not working hard. Everybody is working hard, but the challenge lies that how do they come together and visualize that how their work is impacting each other. And that's where this data driven policy making or data driven action takes a very, very important role. And some of the elements which Sinha sir explained about Mission Antodaya, where the village has been basically mapped for every particular sector, education, health, performance of every sector is elaborated. I think that's where we need to move forward. Sir, over to you to explain it further.
Yes, Mr. Amarjit, please, if you have thoughts or advice on this complicated question.
In fact, I know it's not just about convergence for health, but as I mentioned in passing, education, health, livelihood, skills, nutrition, all these 5 sectors don't lend themselves to narrow departmentalism or narrow ministerialism, so to say. So they actually require to be on a common platform. So that's why when I talked about human development trust in all nations, the idea was basically to have this local and global at the same time, where you actually push institutions to be accountable to local community organizations. And you also set up systems that look at the interlinkages of these sectors. Because clearly, wherever we are able to resolve the challenges of the last mile, even on nutrition, where India has many challenges, we find states like Sikkim, for example, by resolving some of those community connect challenges as also some of the wider determinants challenges, they're able to do much better. Because if there's undernutrition, it's not just on account of food. There are a whole lot of other factors which have to do with availability of basic medicines, which have to do with availability of clean water, which has to do with behavior change, communication, and so on. But I think broadly, there has to be a well thought out mission which encompasses all these 5 sectors. Because, I think very fragmented, it's not only about health coming together. So in India, if I look at the rollout, and as I said, my last 40 years have been in these sectors, we tried first some kind of a sector plan for elementary education with Sarva Shiksha Abhiyan. Then we tried a sector plan for health with the health mission. Then we tried all our rural livelihood, housing, sanitation, all programs as part of a rural sector. Now, having coalesced internal individual small schemes and getting the interactions among each other, we now actually need to get these 5 sectors together. I think this is a principle which holds universally, and clearly in our thinking process on the trickle down and the human development, we are missing a piece in terms of not recognizing what asset deficits to the ability to access public services. Thank you.
Yeah, thank you. And a comment in the chat that is very relevant, that it's really understanding what's going on in the field or at the local level that's really important, that those of us who sit on Zoom chats like this and talk about things in general terms are helpful perhaps, but really understanding what's going on at the ground level is really critical. I have a question for you, Dr. Tamaru. I'm interested in, you could reflect a bit on sort of some of these same issues around getting everyone involved from different sectors in terms of water transformation and the Sakota Declaration. What were things that facilitated that kind of working together, and what were things that were challenges?
Thank you, Sylvia. So in terms of the facilitation, the facilitators to bring these stakeholders or sectors together and the challenge around, I think sectors are created because like government to answer the public question and public problem. They organize structured in terms of silo. So that kind of, there is a water sector, there's an education and health sector. That helps because it addresses some critical issues. But in terms of bringing change that is sustained at the household level, there is no sector in the household. There are families, father, mother, kids, and so on. If we anchor all our intervention at the household level, we don't think of sectors around. So bringing that kind of concept and translating all the sectoral initiative into a family level brings intersection. So nutrition is one of the major problem around the country with high level of stunting, and the major challenge, determinant challenge of nutrition at the distal level, proximal level, and other were identified. Initially, it was like, to your surprise, the stakeholders at the beginning was health, education, water, and agriculture were the sector working around. There was no transport sector. And during the exercise, after the implementations of some year with the multisectoral approach to answer food diversification, to improve food production and utilization at the household, the community level, that was understood that the road was the critical element that hinders the availability of food around. So the road sector was being discovered to be one of the rate limiting, even it was one of the critical area. If the road is available, we can access food around the nearby village and so on. So this is a kind of learning model from the community, the aspiration that we had and the understanding of the local context was the critical element. They all have interests around the nutrition and they work together, and additional sectors were coming around. And the most of the challenge were excluding some of the sectors that were very critical at the early stage, and later understanding through the process and the discussion to engage them later, the industry sector, the partners, and then working together to see the Sakota declaration moving forward. There was no resource dedicated at the beginning. Later, government has also dedicated a separate resource for this, in addition to the partners and the mobilization. Thank you.
Great, thanks so much. Some more questions in the Q&A and the chat, some really interesting and important reflections about the fact that different sectors may have competing interests, that in fact working together may not be particularly straightforward. And I'm wondering if either Shalini or Amarjit, do you have examples of this from the Indian context? Perhaps a place where competing interests exist, and then perhaps what may have been done to work through that, or who takes the lead is another question that's coming up a lot related to that, right? Competing interests might be also about who has control and power in a given situation or initiative, of course, too. So interested in those thoughts about sort of the politics of working across sectors. I appreciate that's a tough one, but Shalini, if you wouldn't mind starting.
Shalini, you want to go first?
I can start. I can give an overarching understanding around this. So based on my interactions with stakeholders here, so who takes the lead? So I'll give a very specific example. There were multiple deaths because of Japanese encephalitis disease in Uttar Pradesh till a few years back. And gradually you will see that deaths of those children have been coming down in the last 3 to 4 years. Now, who took this lead specifically in the district where the burden was very high? The lead comes from the very top. So that's what we mean by political commitment. If the top leadership is involved, if the chief ministers take a lead, and the highest political representatives take a lead in bringing all stakeholders together, yes, that's what drives these multisectoral initiatives, if it is a political agenda. The other example, which I feel where good outcomes have been observed because of the leadership is the COVID-19 pandemic. It is a very classic example, especially in the Indian context, of the whole of government approach, where every stakeholder, right from national, district to the sub-district level, came together. Every department came together for the pandemic mitigation efforts. So that's about taking the lead. And so I'm forgetting what was the other part.
Well, I think it's related to that. I think that it's about what to do when there's competing interests.
Yeah, so with respect to power hierarchies, I think that never came in some of the interviews and the explorations which I have done. It's not that one department is over another and they have competing interests. That never came. But of course, the issue which emerged from the ground level perspective was of limited resources. Each we are challenged with limited resources. That's where so again, it comes down to more than competitive interest. It's like there are resource limitations in every sector, and sometimes that needs to be taken care of. So over to you.
In fact, that's very well put, because essentially there are many it's almost like a PERT CPM exercise. Many things have to go on at the same time to be able to deliver a service, whether it is technology, whether it is community connect, whether it is water, whether it is sanitation, whether it is housing, in many of these sectors. And that's why, the local governance becomes very, very important. And the level of integration depends on that. Now, if programs choose to keep away from it, which has been the case with, say, even the ICDS program, in terms of the institutional involvement of panchayats, even in health and education, our finance commission has been recommending it, but the concerned ministries are still taking a little longer than they should in conforming to it. And I think it has, that's why, I think it's important to uh, build institutions with that community connect to be able to create a functional system for outcomes. And I think this is where the successes as also some of the failures get explained in the context of some of these partnerships. Wherever we are able to build a community connect well, say electricity connections, gas connections, sanitation, toilets for every household, rural housing, many of these programs, the increase in immunization from 64% to about 77, 78% now, full immunization. A lot of it has to do with this working together at the cutting edge level. I recall running a mission in 2018 called the Gram Swaraj Abhiyan, which was basically covering 63,974 purposively selected villages, primarily belonging to the most deprived communities, where more than 50% of the population came from deprived households. And the task was to provide 7 services, from a bank account to an accident insurance, a life insurance, immunization, electricity connection, gas connection for cooking, and LED bulb use so that the power bills are lower. Now, when you have a focused attention of this kind, but these were finite deliverables. But when you're dealing with systems like education and health, while similar approaches can work, but with some changes. And clearly, there's no going away from HR, for example. The 2 billion vaccination, I think it just, whatever, none of the scale is not possible without technology and community connect. And a whole lot of research, for example, partnerships are public and private. They may be private providers for vaccine, but a lot of their testing, a lot of their further understanding of what is working, not working, public labs have also to get involved in that process. So I think creating platforms for joint action and forgetting the binaries of private and public, central and state and local, I think that's a challenge. It's not easy at all, but it can come with practice. It happens during emergencies, disasters, doesn't happen in normal times. How do we make it a practice of normal times? And that's why a human development mission. Sorry to be coming back to it every time, because it's a passion which I think will give us far better results than what we get so far. Thanks.
Great. Now I have a question which is close to my heart as someone in a university. Is there a role for universities in all of this? So I wonder if we can start perhaps with the Ethiopian experience and then ask for additional reflections from others if needed.
I think this is a a good question. Maybe universities and education sector, basically in terms of their capability and competency, there would be a good resource in terms of engaging within the multisectoral to realize primary health care and universal health coverage. They could help in bringing new innovations and come up with a kind of new design and research and new implementation sciences around. And so far, there has been a kind of link toward this community. Most of the time, the universities would focus on the areas of training, research, and so on. So bringing their area of interest to intersect with the primary healthcare and multisectoral would maximize their engagement and would improve their appetite, as well as would help them to be part of the multisectoral, and the other sector would use of their capacities around research and training around documentation and so on. So that is very helpful. There are expenses around, but it should be maximized.
Yeah, great. And related to that, another question, an excellent question that came up is, what about donors and development partners? Usually have vertical agendas. How do we get them to work in multi-sector collaboration in a productive way? How do you pull them in? I'll leave that one open for any thoughts from anyone who has experience or insight there. That's a challenging one.
Maybe just to give you a real experience we had, like as during my presentation, so parking intervention around the household, the community, and the district level would help to pull the vertical resources around that pillar. So whichever donor or implementing partner with a vertical program could be integrated within the multi-sectoral. So that would balance the vertical interest within the existing horizontal or specific and multi-sectoral engagement. So we have an experience of there is a project that donors were interested to come up with expanding water service at the community in Gimbichu. So that was one of the area of the pillar that we spread over the household level, the community, and the leadership level. And that was aligned with the existing multi-sectoral, and the donors were happy, and even that was integrated to maximize multi-sectoral. So vertical program could be integrated if there is a platform to address that thing. Then that's also one of the experience that we had in terms of water, education, and so on. There were multiple partners that anchor on the existing multi-sectoral platform.
If I could just add 2 lines agreeing with what you're saying, the vision has to be national. It's very important that the policy is actually formulated in governments. Donors should desist from formulating policies. In the overall frame, overarching frame of the policy that national governments decide, depending on the financial resource situation, and that's why it will vary country to country. Some countries may need a sourcing of 10%, some others may need a sourcing of 50% from development partners, whatever it is. But let the overarching frame be national. That's important because then there is ownership of the framework. The second thing which is equally important is that, there are certain responsibilities of convergence, MIS for one. You're absolutely right, this verticalization and the horizontal coming together. The PHC as a horizontal unit will never come together because everybody wants their own, UNFPA has a certain demand, WHO has some other demand, World Bank projects have some other demand, all of them depending on which area they're putting their money into. They want a system only for that. I think some stepping back is needed for an organic health MIS to emerge. This is just a suggestion. I can get into details of it if you want with concrete examples, but not today. Actually, I'm so sorry. I needed to. Somebody, a friend of mine's mother has died. So today is a thing which I have to go for. And if you don't permit me, I leave 10 minutes before time.
Thank you so much for joining us and sharing your expertise. It's much appreciated.
Thank you.
I would like to, we have an audience, a participant in the webinar, Sylvia Esther, who has some experiences from Uganda that we would love to hear about. So Sylvia, please do unmute yourself if you're there and share with us. I think you're mute out there.
Thank you so much for this opportunity. There's a question that came in the chat of how you can be able to work hand in hand with your government. Sorry, I have noise in the background. I'm from the field. I'm Sylvia Esther Naku, a community health supervisor, Living Good Uganda. And we basically deliver community health through village health teams using digital health equipment. And the challenge we faced while we were rolling out this is government already had village health teams in place, and they were also delivering community health like we're doing. So we faced a challenge of penetrating through the communities because the government felt there was a bit of conflict of interest from their end. However, the challenge we faced with their VHTs is that they were not well equipped as compared to ours. They didn't have digital equipment. Those are the phones, the smart health equipment they use in the community to get the data, but also the medicines they were giving them were sort of not enough, or they were not consistent in the supply. You could find that one month they have and the other month they do not have. While Living Goods were actually supplying these village health teams with medicines, they were always in stock. So even when a child had issues in the night, you'd find that a community health worker for Living Goods was in stock of medicine. So through the engagements, we were trying to show them that we want to work hand in hand. There's no conflict of interest whatsoever, but they need to understand there's a better approach to this. They needed digital health, which their village health teams did not have. So in one way or another, our government actually has just discovered that Living Goods is actually doing a much, much better job through the support from the government. And recently we've even had the CEO coming, Gavi CEO coming to Living Goods. He went to the field. He witnessed the need of digitalized village health teams to better smoothen the work they do in the communities. And as of now, I tell you, we are on a roadmap to working hand in hand with government, which was not the case in the beginning. We found a lot of hardships trying to penetrate, like the issues are coming through of how can you make sure you're working hand in hand with the government and not ensuring there is conflict of interest. So just ensure the government clearly understand your mandates, and then you'll be in a better position to work in hand with the government. Because as I speak right now, we were working hand with the Ministry of Health, government. We're also working hand in hand with the other stakeholders still under Ministry of Health, and they're even planning on helping us finance some of these things that we put into consideration. So I think at the end of the day, government will also get to understand that these other implementing partners can also do a much, much better job with the support from the government. Thank you so much for the opportunity.
Thank you so much. Some great comments there, and a reminder of how complex this is, right? It's not just different sectors within the government that need to be considered. It's also other actors on the ground, right? Other people who are really doing quality community health work in various ways across a lot of different sectors need to be engaged. And that's a challenging and complex thing. One thing that's come through very strongly in the chat, and I think is really worth underlining here, is just the importance of context-specific work and the importance of work that's done on the ground. That national level political leadership is critical, but that the actual work happens at the local level. And so this has to happen at a bunch of levels, and what happens at the ground is really critical. And I'm not sure, Shalini, if you have any final thoughts on that topic.
No, I totally agree with you, Swaya. In fact, one of the key challenges with multisectoral collaboration have been these top-down approaches, which have just been thrusted upon people who work on the field, work on the ground. And a key challenge across has been, why do these not work? Because these ground level stakeholders are never consulted while designing these approaches and policies and interventions. So a bottom-up approach, and that's what someone very beautifully had put forward to me, that in contexts where there is a culture of social governance, and Mr. Sinha also pointed out that involving communities is critical. So as one role of academic institutions is to come up with implementation research on these bottom-up approaches for multisectoral collaboration. Keep trying and start off with the key challenge which is there in your context. Let's say for India, it's nutrition or anemia, but come up with these bottom-up approach and bottom-up solutions.
Thank you so much. Thanks so much to everyone for your time, attention, engagement in the chat. It's been wonderful to engage in this conversation with you. Please keep posted for more webinars from IPHCE as we move forward. This is, of course, a series. I know that many of you have been following along with this webinar series all along, and that's much appreciated. And we look forward to seeing you again at another webinar soon. So thanks so much to everyone. Have a lovely evening. I think for most of you it's morning here, but I believe for you, most of people here, it's evening. Thanks so much. Have a lovely evening, and hope to connect with you all again soon. Please do give your feedback on the survey that was posted in the chat. So just take a moment now just to click on the chat and to do that survey. Also, a reminder to follow IPHCE on social media, where you can get information on additional webinars and other opportunities that the Institute has. So thanks so much, everyone.